Okay, good morning, everybody. Thanks for joining us, and thank you to our sponsors, Amgen and AstraZeneca. It's really my pleasure this morning to introduce Dr. Aaron Baggish. He's the founder and the director of the Cardiovascular Performance Center at Massachusetts General Hospital in Boston, which is the United States' first program designed to provide comprehensive cardiovascular care to the athlete. He's an associate professor at Harvard Medical School in Boston. He's the medical director of the Boston Marathon. He's the cardiovascular physician or team physician for U.S. Soccer, U.S. Rowing, the U.S. Olympic Training Centers, the New England Patriots, the Boston Bruins, and numerous universities. His research interests include exercise-induced cardiac remodeling, pre-participation screening, sudden death prevention, exercise dose, and clinical outcomes. He's really the leading authority in the field of sports cardiology. He's authored or co-authored many of the seminal papers over the last couple of years, and as well as the scientific statements. And this includes the era of COVID, which could be its own separate talk. Today, he will speak to us on sports cardiology 2021, past progress, and future challenges. So Aaron, thanks so much for joining us. I wish it could be in person, but I'm sure it'll be a great talk.
Thanks, Kevin. Nice to see you, and I very much appreciate the invitation to be with you. Let me go ahead and share my screen here. Hopefully everyone can see this now in slideshow mode. So what I'm going to do this morning is spend a little bit of time talking to you about the field of sports cardiology and try to impress upon you that no matter what type of cardiovascular medicine you practice, this is a relevant population and topic for all of us. And so this is really a talk about where we've been and where we plan to go. Disclosures as shown here, both affiliations as well as funding sources from my research lab. So let's get right into it, and I want to start everyone off with a quick case presentation this morning. This is actually not a patient of mine, but a friend, an old training partner. And those of you that have heard me speak in the past will have heard this case, but I just can't get away from it because it's so instructive. It's a 32-year-old male professional marathoner who presents to an emergency department with fatigue and acute pleuritic chest pain to the sensation of chest discomfort while breathing in and out. He's seen by an emergency doc and ultimately a cardiologist and given the diagnosis of viral myopericarditis. So obviously a diagnosis is very, very relevant in the time of COVID-19. He's prescribed some NSAIDs and told to lay off activity for a period of time, and he does quite well. A couple months later, he's given the green light to start training again, and he emails his cardiologist and he says, "Doc, all is well. Feeling good. Think the NSAIDs did the trick, hoping to PR at my next race." So for those of you that are athletes or perhaps work with athletes, you'll recognize the acronym PR, which stands for personal record. This is an athlete reaching out to his or her physician and asking for the green light to go ahead and push with unrestricted effort. And his well-intending cardiologist writes back, "Racing again sounds fine. However, I'd prefer you take your medication orally, not PR." Now, it's horribly frustrating to tell this joke without hearing anyone laugh, but it's actually, in addition to being humorous, it illustrates one of the challenges in sports cardiology, or the challenges in any type of medicine where you're dealing with a specific population in which they come to the clinic with a specific lingo or jargon and goals and objectives. And if we as clinicians are not in tune with that, it's going to set us up for some really awkward and suboptimal interactions. And this is very much a problem, or it historically has been a problem in sports cardiology, because the typical model involves some athlete who on a daily basis was surrounded by a coach and an athletic trainer, perhaps a sports medicine doctor from the fields of orthopedics or primary care sports medicine. And we as cardiologists were very much on the periphery, only called in when there were difficult decisions to be made about eligibility after a diagnosis or perhaps placement of a defibrillator or medical therapy. And this really set us up to be suboptimal in the care team. And this is a problem because as we think about demographics in most developed countries, certainly in the US, the number of men and women that are pushing their bodies hard, not only at the young high school and collegiate ages, but across endurance events, whether it's road races, triathlons, or in the CrossFit gym, the number of people that are doing these activities and really including these as an important part of their daily lifestyle has never been higher. So fortunately, particularly at the professional and the collegiate level, the scheme has changed quite a bit. The athlete remains at the center, but the number of stakeholders has increased dramatically. The coach, the trainer, the sports medicine doc are still there, but increasingly there are recognized stakeholders that weren't there in the past, including administrators, family members, lawyers, agents, and most importantly to this audience, cardiovascular docs. The American College of Cardiology has very much taken a leadership in this space and put together an advisory board, now a decade old. Membership in this section is actually the highest membership across any of the sections, including cath, EP, heart failure. So it's certainly something that ACC members are interested in and want both education as well as advocacy around. I've had an opportunity to be a part of this since the beginning, and it's been an amazing journey. And what I want to do is just show you several documents without getting into them in any detail that I think are most relevant for your practice as a place to turn should they be relevant when specific patients come through your door. The first is the so-called ACC white paper, which is now 7 or 8 years old, in which this group got together and talked about what the field of sports cardiology looked like and where the challenges ahead lay. Many of these were research objectives and policy objectives, and many of them are still quite alive and well. The second, and I'll talk about this in more detail, was the now termed AHA-ACC eligibility and disqualification recommendations. These were an update of the 36 Bethesda conference proceedings, which many of you are familiar with, and again, I'll talk about in some detail. Next came the partnership with the NCAA, in which they said, look, college sports need some input with respect to how we keep athletes' hearts safe, both from the screening perspective as well as the emergency action planning perspective. And so this was a document that represented that collaboration. Next came an attempt to really standardize ECG interpretation criteria in athletes. And again, this is a document that really provides an overview of what it should be considered normal and what should be considered abnormal in athletic patients. And I think is a useful tool in the clinic when these patients present. Next was a core curriculum, which was designed primarily for educators to really help people think about how to wrap in the concepts of sports and exercise physiology into the traditional educational model. And then finally, just last year, the first real imaging standards, in which a group of us got together to think about the use of multimodality imaging in this population. So again, these are documents that I don't have an opportunity to review in any detail this morning, but I just wanted you to be aware that they're out there. So should they be necessary or useful, you know where to turn. So as Kevin mentioned in the introduction, I started and continue to run the cardiovascular performance program, which is a center in Boston where we have a simple mission statement that is to provide comprehensive world-class clinical care and research, focusing on prevention, management, and performance enhancement for athletes and active individuals. And in order for this to work in a tertiary care medical center like yours or mine, there have to be a couple of different things happening. One is we need to do things that really enhance the institutional mission around clinical care. And this is where we spend the majority of our time working in both a busy consult as well as a longitudinal care service. We also do a fair bit of pre-participation screening, which we consider a community service rather than a revenue generator, and have a busy exercise lab where we do a lot of performance optimization for elite and professional athletes. And then the part that is most near and dear to my heart is really the research side, where we're thinking about what we can do to advance science in the field and make this relevant and digestible to clinicians around the world. What's exciting to me is that when we started this program back in the mid 2000s, 15 years or so ago, this is what the sports cardiology landscape looked like. Fast forward now, and this is incomplete, I realize, but these are only the places that I know of, having worked with them to get programs started. This is what it looks like in 2020. And so a majority of major tertiary academic medical centers now see this as an important part of their service line. And that's because the communities ask for it and because it generates revenue and really enhances the overall institutional mission. So these are the people that we typically take care of, and indeed they are really two populations. There are folks in the first half of life. These would be your high school, collegiate, and professional athletes. And then there are folks on the second half of life, master's athletes, or people that require high levels of physical activity for their occupation, whether it's in police, military, emergency medical services. And so when we think about sports cardiology, we have to remember that there are really two distinct populations, both the young and the older. And I'm going to spend a little time talking about where I see the fundamental challenges in both of those age groups this morning. So the first 10 minutes or so have been about progress, but while we've made some progress, as the Vermont poet Robert Frost said, we have miles to go before we sleep. And I want to just spend the rest of this morning sharing with you my thoughts about where we have the greatest room for growth. The first is with respect to eligibility among young athletes. And we really don't truly understand the natural history of many of the key diseases that we work with, whether it's the cardiomyopathies or the primary electrical abnormalities, particularly when we're talking about the risk-benefit ratio of superimposing high intensity and high volume exercise. And so this boils down to, what should we as clinicians support our patients in doing following a cardiovascular diagnosis? And again, this is a controversial topic without any answers, but I'll talk you through a little bit about my thoughts. The second is the issue around how we think about therapeutic decision-making. And this is really an issue with respect to masters athletes that develop many of the common diseases that we're all very familiar with, whether it's atrial fibrillation, coronary disease, hypertension. And one of the challenges is that we have almost no primary data derived from that source population to make clinical decisions. All that we have is extrapolation from general population studies and or expert opinions. And while this works, it's not optimal. And I'll share with you some of the challenges and some of the misconceptions there. So let's talk a little bit about eligibility for young athletes. And what I'd like to impress upon you is that the era of paternalistic care is over. These are 4 patients of mine: Clint Dempsey, who was a prior U.S. national soccer team captain; Charlie McAvoy, who's a defenseman for the Boston Bruins; Joanne Reed, one of our U.S. Olympic biathletes; and Jeremy Tobis there, who's an elite level cyclocross racer. And all 4 of these folks have come to us with cardiovascular disease or cardiovascular concerns and asked the question, can I keep playing? And the answer always is, let's talk more. The challenge is that historically, there has not been a lot of wiggle room, at least as put forward by experts across several decades. This is the initial Bethesda conference proceedings, which was a document released in 1985. This is a compendium of cardiovascular diagnoses, and it's a pretty simple document to use. You look up your diagnosis of choice, and the document pretty much says the same thing irrespective of the diagnosis, and that is, if the athlete has it, they're done with sports with the exception of the Magic 5, bowling, cricket, curling, golf, and riflery, which is not a particularly desirable list for many. And this set the stage for very much a paternalistic doctor controls athletes sort of mentality, which has been pervasive over the last several decades. Fortunately, and I think a move in the right direction came several years ago with the partnership for the first time, between the AHA and the ACC around eligibility and disqualification. And this is the current document. What is it? Well, it's actually not one document. It's a series of task force documents that is divided into topics and diseases. It is really a document that's designed to provide information or guidance around when disqualification or restriction are appropriate and when not. This is geared to competitive athletes at the high school, collegiate, and professional level. And there are some interesting things about this document, that some of which are new and some of which are not. The first, which really harkens back to the first iteration, which is now 40 years old, is that athletes may in some cases be a limited control population, meaning they may not have all the tools necessary to make the best decisions on their own behalf. So there's very much a role for doctors and other people that play a role in their care, whether it's their coaches, their trainers, their administrators, to help with decision making. What's exciting about this new document for the first time is the addition of Class 2A and Class 2B recommendations. So it's no longer a binary, you can play or you're relegated to the Magic 5, cricket, golf, billiards, riflery. It is in many cases now reasonable to consider athletic participation for athletes with some very common previously prohibitive conditions. And these are things you'll all be familiar with in clinical practice. I'll show you them in a second, but what I also want to impress upon you, one of the weaknesses, and this is an unavoidable weakness because of where we are with respect to primary outcome data, is there's not a single Class 1A recommendation to be had in this. So again, this is a document full of opinion and full of anecdote, which is useful, but we have to remember what the level of evidence is. So Class 2 recommendations are now quite common, and about 25% of the overall recommendations in this document are now Class 2A, which again indicate that full participation may be appropriate for athletes with things like anomalous coronary arteries, implantation of an ICD, left ventricular non-compaction, revascularized coronary disease, transplantation recipients, channelopathies. And so this is both progress, but also a challenge. And these are recommendations that really necessitate a process. The old days of it being black and white, which were quite easy for us as clinicians, are really over. And so things have gotten more complicated. So how should we deal with this? Well, if you think about the decision-making control spectrum, on one side you have the paternalistic gray-haired doctor who knows best, and on the other side you have the patient that wants autonomy. Paternalism is something we all know, and we all, in some way, shape, or form, unavoidably practice, and this is that doctors know best when it comes to sports. clearing athletes is our job. The process is simple. Why make it complicated? Well, on the other end of the equation, you have the athlete or the patient that's saying, doctors don't always know best. We as patients are individuals. There are both medical and non-medical issues that need to be considered in the decision making. And why make it complicated? Because it is. And so bringing these two together, as most of you are well aware, this is not new to cardiology, but it's newer to sports cardiology, is the concept of shared decision making. And this is really the so-called sweet spot. So there have been some things written about this, certainly the concept of bringing shared decision-making into the young competitive sport arena, something that I've worked with Mike Ackerman at the Mayo and with Rachel Lampert at Yale quite extensively on thinking through about. There have also been some nice opinion pieces around the importance of doing this in some of the primary cardiomyopathies. More recently, we put together an algorithm for how to do this in the athlete arena. So if you're interested, this is really a how-to document. And while this is great, I think one of the things I lose a little bit of sleep about is the fact that we really don't understand the impact of shared decision-making for athletes with heart disease. It's completely untested, and thus both the pros and the cons of being more liberal are 100% speculative. We have lots of anecdotes of this working out well for athletes and some where it hasn't worked out quite as well. And so this really needs to be studied and vetted to ensure that the benefits outweigh the risk. I'm pleased now that I think we have a platform in place to begin this journey of scientific inquiry. And this comes in the form of the ORCA registry. The ORCA registry is the outcomes registry for cardiac conditions in athletes. It's an enterprise that I am working closely with in partnership with John Dresner and Kim Harmon, two sports medicine docs at the University of Washington, and now with support from the AMSSM and the American Heart Association. And the goal of the outcomes registry, which was actually conceived of well before COVID-19, was to engage colleges around the country who had athletes with cardiovascular disease who continued to play or who were restricted, in an attempt to really study what happens to these people, both those who are continued participants as well as those who are removed from sports, and to understand the impact of those two very different trajectories on the health and welfare of these people. And so this is a registry which is alive and well, and I think once COVID-19 is over, we'll pivot in that direction. As some of you may have seen last week, we put forward the first paper from this registry, which was indeed specifically dedicated to COVID-19. And among 42 participating colleges and universities from 23 states and most of the major athletic conferences, we were able to look at just shy of 20,000 student athletes that came back to NCAA participation in the 2020 fall season, of which about 20% were SARS-CoV-2 positive, the majority of which underwent cardiac evaluation. And so we had an opportunity in just about 3,000 people to ask the question, what type of heart conditions would we find? I won't go through this in detail. The paper is available online now, but suffice to say, it's the same old story with screening, that when you look at healthy populations, you don't find a lot of disease, but you do find some. In this case, we found a prevalence of inflammatory heart disease attributable to COVID-19 of about just shy of 1%, so 0.7%. But we also found lots and lots of people at a 3-to-1 ratio, actually, that had other cardiovascular things that were non-COVID related. And so this really forms the foundation, if you will, for the quest to understand what the natural history of playing with these conditions looks like. And so this is really where the registry will pivot once COVID-19 comes to an end. So the eligibility and shared decision-making challenge is alive and well in young athletes, but I want to switch gears and talk a little bit in more detail about what I think is really the true bread and butter of community-based sports cardiology, and that's the care of the master's athlete. This is Ted. He's a patient of ours here in Boston, seen here rowing on the Charles River. And Ted is an internationally recognized oarsman in the 70-plus age group who's won virtually every regatta anywhere in the world that one could enter. And he does so while co-managing coronary artery disease, atrial fibrillation, hypertension, and an ascending aortic aneurysm. And what's interesting about Ted is that he's thoughtful, he's motivated, but every time he comes to clinic, he asks the question, is my athletic background, are the sports that I love doing making me healthier or less healthy? Have they caused my cardiovascular disease? And These are great conversations to have with patients. Sometimes we have answers and sometimes we don't. But let's use TED as a paradigm or an example of the master's athlete, which we'll define as any man or woman above the age of 35 who exercises vigorously for at least really 5 hours a week and emphasizes goals. Now, the goals may be competitive, external, they may be competitive, internal, they may be simple recreational pursuit, passion, but they're goal-focused people that push their bodies hard for some reason. Why do folks like TED appropriately worry? Well, they worry because there's been a fair bit of interest in whether you can get too much of a good thing. I don't remember November 27th all that well, but I remember November 28th, 2012. I came into work and there were something like 500 emails in my in-basket, and they were all about this editorial, which was posted online the night before in the Wall Street Journal, which was entitled "One Running Shoe in the Grave," in which the editorialist writes that running too far, too fast, and for too many years may speed one's progress toward the finish line of life. Now, this common lay press editorial was based on a scientific editorial that was soon to be published in the British journal Heart. Many of you will be familiar with this, written by Jim O'Keefe and Chip Lavey, both good friends and cardiologists, very thoughtful guys that have wrote a piece called "Run for Your Life at a Comfortable Speed and Not Too Far." And in this piece, they use 4 lines of evidence. They look at some old epidemiologic data. They tell some stories about athletes dying during activity. They look at some new pathology data, and they point to some new emerging epi data. And they raise the issue that perhaps exercise, which all of us think of as being good, can exceed a threshold at which it becomes bad and end up doing more harm than good. Unfortunately, this line of evidence, which has been looked at in detail, hasn't really stood the test of time. It's a great read if you're interested, but a lot of the arguments put forward here, which have now been vetted, fall a little bit short. But what I will say is that I think, for the most part, when there's lots of smoke, which this article caused, there's usually a little bit of fire. And so I think as responsible clinicians, it is important for us to ask the question, does too much exercise over too much time hurt your heart? And importantly, if so, does it affect morbidity and mortality? And what might this pathology look like? So why should we talk about this topic now? We should talk about it now because there are new data sets which push the issue. First is there are a number of emerging epidemiologic studies with a focus for the first time on the high end of fitness, which show that at some point there are at least diminishing returns, meaning at some point you can't move your blood pressure, your cholesterol, your glucose metabolism any further in the right direction. There are increasing numbers of anecdotal observations of physically fit people dying. These are people we consider immune from cardiovascular disease, and they die during exercise, and perhaps maybe in some cases it's due to heart disease that sport may have participated. And then there are some observational data which now describe unique forms of cardiovascular pathology among athletes and athletic patients, and I'll talk about some of that in detail. And really, if all of these things coalesce, I guess it's possible that there's a syndrome of cardiovascular abnormalities that's caused by chronic exposure to high volume of exercise. So let's go back to medical school for a moment and think about dose response, because I think when people ask me how much exercise I should do, the next question I have for them is, well, it depends on the outcome and it depends on who you are. And one way to think about this is to remind ourselves that when we expose an organism to a stimulus, whether it's a medication we give our patients or it's a prescription for a procedure, the response is always defined by 2 curves, an efficacy curve and a toxicity curve. And what we hope when we're intending to do something that helps is that we give a dose that allows patients to live in the margin of safety, where they experience efficacy without toxicity. But what's challenging, and I think most of you are well familiar with, is that not all individuals adhere to dose response curve. We have benefit outliers who get lots of benefit at very low doses, and some who get almost no benefit despite toxic doses. And we have toxicity outliers, people that experience toxic exposure at very subclinical doses, and those that show no toxicity when they get doses that are far in excess of what we would ever prescribe. And when it comes to exercise, it's even more complicated because the dose response curves can take many shapes. You can have curves that look like this, 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 and this. And it behooves us, when people ask us how much exercise I should do, to really dig a little deeper and understand what outcomes that they're thinking about. So when you look at curve A, the linear curve, and someone says, what does that reflect? Well, that's a good representation of race performance. Typically, the more you train, the faster you'll race. What about the asymptotic curve in panel B? Well, this is a great way of displaying the relationship between exercise and cardiovascular risk factors. When you go from doing nothing to something, you dramatically improve lipids, blood pressure, central adiposity, all the things we know contribute to cardiovascular disease. But at some point, you'll reach a threshold at which there will be diminishing returns and no further return on investment. The curve on the lower right of your screen, the bimodal curve, is fascinating. This is actually the curve that represents the relationship between exercise and weight loss. And that is going from doing nothing to something will stimulate some weight loss. But in order to really stimulate meaningfully weight loss that can be maintained, you really have to do a lot of exercise, typically 2 to 3 times physical activity guidelines. And this is a challenge and a very sobering message for patients. And of course, curve C, the bell-shaped distribution, is the relationship between exercise and, of course, marital success. If you spend too much time training, your partner will leave you because you're not at home during the weekends to spend any time with them. And this is actually, all joking aside, an issue for a lot of endurance athletes. So what do we know about lifespan and people that push themselves hard? Well, the best data come from Northern Europe, from Finland, and this is really a story of the legacy effect, in which the Finns have been able to capture mortality in their Olympic athletes over many decades. And what you can see here is by about the age of 50, there's a divergence of mortality curves in which endurance athletes tend to enjoy slightly longer lifespans than sedentary reference or power athletes. And here are the numbers underlying these curves, that in Finland, endurance athletes tend to live into their mid-70s, whereas sedentary reference, 5-6 years shorter lifespan. Team sports like soccer, ice hockey, basketball, somewhere in the middle. And interestingly enough, power sports like wrestling, weightlifting, boxing appear, at least in this population, to confer no mortality benefit. Well, what's interesting is it's not only how long you live, but how sick you get that appears to be, at least in part, determined by your athletic capacity at a young age. These, again, are data from Finland, which show quite nicely that admissions to the hospital for many conditions, probably most relevant for this audience is ischemic heart disease, is very much protected against among those that participated at a high level in either endurance or team sports. It is interesting that the power sport athletes here appear to be more at risk for ischemic heart disease, and that's actually a topic we're spending a lot of time studying right now, and that is what high intensity strength work does from a health and longevity perspective. But there's clearly a signal there that it's different from endurance activity. But you know what? It's interesting. I mean, how good is it? Well, at one point, the California-based pathologist Thomas Bassler wrote a fascinating article in which he proposed that the ability to run 42 kilometers or 26.2 miles, the typical marathon, would confer complete immunity from atherosclerosis. And that his hypothesis was that if you were able to run that much in a single time, and perhaps more importantly, if you trained to do that, that there was no way that atherosclerosis could develop in your arteries, and that there was really a chance at immunity if you either were able to or chose to do this type of activity. Now, that was unfortunately way too good to be true. We've learned that from many places, but one that I had the opportunity to oversee was the RACER registry, which is now a decade old. But this was an opportunity to study death and cardiac arrest during long distance road races here in the United States. And I won't belabor the details of this study, but one of the things that was most interesting is that among older runners, and again, we use this somewhat arbitrary cut point of about 35 or 40 years age, among older runners, coronary artery disease was indeed the most common cause of cardiac arrest. But what was interesting is that these athletes were typically pretty easy to resuscitate in comparison to younger athletes with genetic or congenital heart disease, that there was something about coronary disease that developed in older athletes, but was amenable to rapid intervention on the scene. So a sobering reminder that this is alive and well in our aging population, regardless of whether they exercise or not. Why do athletes get coronary disease? Well, I'm going to return to this in some detail toward the end of the talk, but it's not a particularly challenging topic to digest. These are some data that come from some local experience here in Boston. This was a study called the Boston Master Initiative, in which we did a health and wellness survey of many hundreds of men and women that live in our community. And we learned a ton about these people from this. The first is that these athletes, although they feel healthy for the most part, they go to the doctor. And when they go to the doctor, they get lots of testing done. They get ECGs, they get stress tests, they get echoes, they get CT scans. And the doctors that care for these men and women are doing this for a good reason. They're doing this because they recognize the presence of risk factors: premature coronary disease that runs in families, prior tobacco use, hypertension, dyslipidemia, even in some cases obesity. And what was fascinating in this group of, I think 800 people, only a quarter of these ostensibly healthy masters athletes were totally risk factor free. About a third had one risk factor, the other third had multiple risk factors or established disease. So again, when we ask the question why these people get atherosclerotic disease, let's remember that they're not that different from the sedentary people that come into the clinic with respect to risk. I think the most fascinating thing we learned, though, is that about a half of these athletes felt dismissed or mistreated during their interaction with healthcare providers because their status as an athlete, the importance of their athleticism, was simply not appreciated or something that their doctors didn't support and identify as part of their care plan. So really a call to action around why the field of sports cardiology is so important to many in our community. So what I want to do in the last 15, 20 minutes or so is I want to ask 4 fundamental questions about exercise and health. And this is really where we get at the issue of too much of a good thing. And I want to really focus on endurance athletes because this represents the lion's share of what you'll see in a sports cardiology practice or even in a general practice that has athletes in the community. And those are everywhere. And that is really questions about causality. And the questions are, do endurance sports cause arrhythmia, cardiomyopathy, aortopathy, and coronary disease? And again, I underline the word cause because it's far too easy when the 55-year-old is wheeled into the cath lab with their acute LAD lesion after running to say that it was the running that caused that. And I want us to really think critically about how we establish cause and effect and why this is important. So let's start with arrhythmias. There's no diagnostic dilemma here. This is a middle-aged marathoner who shows up in the clinic with decreased exercise tolerance. And indeed, the ECG reveals all we need to know. This is atrial fibrillation. And there have now been a number of very nicely done case control studies looking at athletes compared to sedentary matched controls. And the finding is consistent across all of these studies, and that is that as men and women age, particularly men, if they continue to push their bodies hard, they're at increased risk of atrial arrhythmias, particularly atrial fibrillation and flutter. Perhaps the most instructive of these studies comes from Northern Europe, this time from Sweden, in which participants in the Vasaloppet, which many of you living in Minnesota who like to cross-country ski will be aware, similar to the Birkie. This is a 90-kilometer ski race in which the Swedes were able to capture more than 50,000 participants over a 10-year period of time with robust follow-up. And they asked the question, is incident arrhythmia predicted by how fast these athletes skied and or how many times they skied the race during the decade of study? And these are surrogates for intensity and volume. And what they found is that both were predictive. So the more races these men and women participated in, and the faster they skied them, the more likely they were to develop arrhythmia, with A-Fib being the dominant issue. So why does A-Fib develop in masters athletes? Well, the simplified and largely oversimplified explanation is one of atrial size. We know from many series that athletes often have left atrial dilation, just like the ventricles. The atria respond to sport, but that's an oversimplification. While remodeling and dilation are part of it, there are other important contributors, including changes in the autonomic nervous system, with persistent vagatonia at rest, coupled with sympathetic surges during exercise, intermittent left atrial hypertension during exercise, inflammation, genetics, lifestyle factors, including alcohol, caffeine, and psychosocial stress. And so when we meet masters athletes with A-Fib, we do spend a lot of time trying to identify reversible triggers, and oftentimes they're there, but it's really a very diverse disease from a pathogenesis perspective. And so what we can conclude when we think about A-Fib in sport is that it is the strongest association between endurance activity and pathology. There's really no argument anymore that our aging patients who engage in high levels of sport are at increased risk for this. Still not 100% certain how much of it is actually the sport or the lifestyle choices that come along with the sport, but regardless, in masters athletes, it's a real problem. But where the challenge lies is in terms of treatment. And this is really where I see the field having the most potential for growth over the next 10 years, because we're stuck right now at a place where we are extrapolating our treatment strategies from lessons learned in the general population and or using expert experience. And we are really without any primary outcome data to help us. And so what do I mean by that? Because, you guys are all cardiologists or cardiovascular practitioners, and A-Fib is something you deal with every day. And you're saying to yourself, what is this guy from Boston talking about? We've got this A-Fib thing figured out, right? We know rhythm control and rate control are equivalent. We learned that in the Affirm trial years ago. We have great scores for dictating bleeding risk and stroke risk. And so we know who needs anticoagulation. This is a calculation you can make in 15 seconds. And look, now that we have catheter-based ablation, why bother with antiarrhythmics? We can just ablate everyone and make this problem go away. And to some extent, there's truth in this, but if you start applying these lessons to a master's athlete population, you'll very quickly realize some of the shortcomings. For instance, are rhythm control and rate control really effective with respect to long-term outcomes? Try rate control enough in this population and you'll get people coming back to you like this, saying that rate control ruined my life. Fastest way to never see a patient like this again is to give them digoxin and a beta blocker and Coumadin and send them out the door. Well, what about anticoagulation? I'm a big believer in anticoagulation. Strokes are terrible. But one of the things our patients push us hard on every day is this question, and that is, were scores really made for people like me? And the answer is no, not really. So we have to approach the bleeding question and the stroke question with some equipoise and talk about what we know and what we don't know. And again, this is an opportunity for shared decision-making. And finally, what about the catheter ablation, which I will be the first to tell you we do a lot of, and it plays a very important role in the management of chronic recurrent, or at least recurrent paroxysmal atrial fibrillation. But the challenges we're learning about ablation in this population is that not infrequently we get ablated athletes come back to us and say that they're cured of their fib, but they're not fixed as athletes. And why is that the case? Well, it's the case because too aggressive substrate modification can leave the atrium very much unable to perform its task, which is to augment stroke volume, particularly at high heart rates. And so while the atrial fibrillation may be cured, ablation can, in some cases, leave athletes worse off than they started. And so we have a lot to learn. And really, again, this is where I see the field having the opportunity to make the most inroads over the next 10 years by studying people like this with these types of questions. So what about heart muscle disease? And again, do endurance sports cause problems with the heart muscle? This is an interesting story, I think, that we've been wrestling with for some time. One of the very early studies we did here in Boston as part of a research collaborative we have with our undergrad athletic department was a study using what was then a brand new technology, strain echocardiography, to look at what happens to heart contractile function with exercise training. And this was a really simple study in which we took 20 collegiate freshmen that were coming in, and they were going to be exposed for the very first time to the high levels of rowing training. And we simply did strain echoes before and after their first 90 days of training intensification. And we were able to look at strain changes and to develop strain maps. And these are what the maps look like. They look at deformation in the three principal vectors. Those of you who do imaging will be familiar with this concept. When the heart contracts, it does so with longitudinal, radial, and circumferential distribution. And the strain story with respect to exercise was largely a good one. That strain appeared to get better or to increase in all of the vectors, with one exception and in one location. And that was that we noticed a consistent reduction in circumferential strain within the interventricular septum. And so the question was why and what did that mean? Well, before we get there, because we didn't know at that point, the other thing we noticed is that the people that had the most septal fatigue were also the ones who experienced the most increase in their right heart size. So exercise physiology has for decades concentrated on the left side of the heart because that's what pumps blood to the muscles. But it turns out that the right side of the heart is as interesting, if not more. And what we were seeing here is that in these young rowers who dilated their right heart, it tended to happen at the expense of septal contractile function. When we wrote this paper, we had one line or two lines in the discussion about the fact that we had no idea what this meant. And still to this day, it's a bit of a conundrum. But what followed shortly thereafter were two very nice studies, both from Europe, one from the UK and one from Belgium at that time by my good friend Andre Lagersh, in which series of masters athletes were shown to have scar tissue in a non-ischemic distribution, largely within the interventricular septum, in the same place that we saw fatigue in young athletes. So the question is, if you do this type of activity over too many years and you fatigue the septum over and over, can that fatigue give way to scar tissue and perhaps a cardiomyopathy? Let's look a little bit in more detail at Andre's study, because it's a really nicely done study that tells an important story. What he did is he recruited 40 well-trained, very competitive folks who were finishing well in races, who were free of symptoms and traditional risk factors, who had no evidence of ischemia on stress echo before enrollment. And he studied them at 3 time points with imaging and with biochemistry. So before a big race, immediately after finishing a race, and then after a week or 2 of recovery. These are the people he recruited. They were marathon runners, endurance triathletes, cyclists. And what I want to impress upon you, and this is always important to look at when you're reviewing or reading for the first time a study of athletes, and that is how athletic are these people. If you call your attention to the third line from the bottom, you'll see percent predicted VO2 max ranging from 140 to 160. Indeed, these are very fit people that push their bodies hard and have high performance potential. And so what happened to them? Well, after they did a race, again, a long triathlon or a running race, their physiology changed, their heart rates were up, their blood pressure, both within the systemic and the pulmonary circulation, was down. But what was interesting at the level of the heart is that the right heart demonstrated clear evidence of fatigue, as manifested by every type of thing you can measure with an echo, whether it was fractional area change, TAPSE, strain or strain rate. While most of this recovered a week or 2 later, there was some persistent reduction in strain rate. But the schematic that arose from this study looks something like this, and that is that when the heart gets pushed and gets tired, the right heart dilates. It pushes the interventricular septum over to the left at the expense of the left ventricular chamber volume, and that over time, this imposes a fair bit of stress on the septum. And in this cohort of 40, indeed 5 of these 40 individuals were found by follow-up MRI to have LGE in the distribution shown here, so largely mid-myocardium within the interventricular septum, with a propensity for this to be present at the RV insertion hinge points. And so what do we make from this study? Well, we make from this study that perhaps if a lot of things come together in the wrong way, you can hurt the heart muscle with exercise. And I think this is really a pathologic cascade, if you will, in which lots of exercise coupled with not enough rest and recovery, superimposed on some host susceptibility factor at the level of the gene. And this is not ARVC genes. This has been well vetted. It's something we still don't understand. Probably most importantly, added on top of a secondary process. So illicit use of drugs, occult cardiac infection, maybe some disease process as simple as uncontrolled hypertension, can in limited, very rare cases cause a heart muscle to do this. And this is really the perfect storm. I will say, in clinical practice, we don't see a lot of this or a lot of this that's clinically relevant. And so I'd say that preliminarily, this concept of exercise being able to cause patchy fibrosis is possible. I'm not sure I'm ready to call it a clinically relevant cardiomyopathy, but I think it's a phenotype of uncertain relevance and one that we need to continue to study. What about aortopathy? This is interesting, and I think, again, something that we're learning as we go. The old story was that exercise training had very little effect on the aorta, so a large case series of young athletes, most of which come from Italy, which has had a long-standing screening program and thus a lot of data, would suggest that young men and women do not dilate their aortas from sport, and that when we find men with an aortic root or sinus of Valsalva measurement of 39 or greater, or women 33 or greater, that this should be considered pathology until proven otherwise, and that indeed it's not sport, but simply height that dictate aortic size in athletes. And this has been the way most of us have practiced and largely applied this lesson to older people, meaning doesn't matter how many years you exercise, your aorta should not get big from it. The concept of sport maybe having some effect on the aorta was put forward by a nice meta-analysis done by my colleague now who's joined us at Mass General, Paul Thompson, who looked at this across large cohorts of athletes and found that indeed young endurance athletes had slightly larger dimensions than non-athletic controls, and this was both present in the ascending as well as the root, and that this was really driven by endurance sports and more common in men. Most recently, we have, I think, the first data set looking at aortic dimensions in a reasonably sized cohort of true masters athletes. So these are national caliber rowers and runners in their 50s and 60s who agreed to undergo aortic scanning with us, either at the Boston Marathon or at the U.S. National Rowing Regatta. And what we found among this group of, again, roughly 60-year-old people with some usual scattering of cardiovascular disease, but importantly, 20 plus years of training, was that a lot of them, so roughly 20 to 25% of these men and women had readings or had values that exceeded these cut points that were gender specific. And none of these individuals had experienced any clinically relevant aortic disease. And so the question now is, when we find these masters athletes with big aortas, is this another example of adaptive physiology, or is this just sport pushing the aorta in an unhealthy way? And really the only way to answer that question is with outcomes data. I will say that not all parts of the aorta appear to be the same, that we see sport type, particularly rowing and being an elite competitor, having much more of an impact on the sinuses of Valsalva, where hypertension seems to be a more potent predictor of the ascending aortic dimension. So it may be that not all dilation is created equal, but I think we need to stay tuned. All of these athletes are now in a long-term surveillance program with us, in which we'll be looking both at progression as well as harder outcomes to determine if any of these folks need to go on for surgical intervention or perhaps more unfortunately develop acute aortic syndromes. My guess is we're going to find out that this is a relatively adaptive phenotype, but again, we need to think about this with some equipoise until these data are available. So finally, in the last couple minutes, coronary artery disease. This audience is well aware of the fact that exercise moves coronary risk factors in the right direction. So whether it's blood pressure, abdominal fat, lipids, truly exercise is magic, and we should be getting all of our patients to exercise more. So where does a study like this come in? This is a 10-year-old study now of marathoners from Germany, in which, when compared to age-matched controls and those matched for risk factors, marathon runners had higher levels of coronary calcium. And indeed, some of these athletes went on to develop events that we as cardiologists would care about. A study in the US, many of you are familiar with, Kevin played a nice role in this study, this looking at participants in the Twin Cities Marathon that had done a lot of running. And again, same thing here. These athletes tended to have more plaque in their coronary arteries, both calcified and non-calcified plaque, than sedentary controls. So when we see studies like this, how do we interpret them? Well, there are a couple of ways. One is the simple way, and that is to say, look, high levels of exercise just cause coronary disease. The second is that maybe it's not exercise, but truly traditional risk factors that are causal and yet underappreciated. Or maybe, just maybe, coronary disease is driven by unknown, unmeasured risk factors and is a totally different beast in this population. So let's go back to the German study and look at the data a little more closely to develop some kind of conclusions about causality. The first thing, again, is that these 4 athletes with high CAC scores who are marathon runners went on to have events, so VT during exercise, a lot of revascularization, and they were indeed accomplished runners, 14, 22, 65, 140 marathons. But when we ask why they developed coronary disease, looking at their risk factor profile tells the story. Runner 1, total cholesterol of 344, a former smoker. Runner 2, a medicated hypertensive, and runners 3 and 4, non-medicated hypertensive with prior tobacco use. So is running really causal? I suspect probably not. What about the Twin Cities study? Well, interestingly, again here, half of the men recruited in the marathon group were former smokers. But what I think is most interesting about this study, and it's not a flaw of the study, it just points out some challenges around establishing causality, is that there's a lot we don't know of. We know nothing about dietary habits in this population. We know nothing about the carefree 20s and 30s of these older men, meaning what did they do early in life that may have started the process of atherosclerosis. And we know nothing about family genetics. And so without controlling for these, establishing causality is really quite challenging. So to illustrate this for you, I want to bring you quickly to the Mount Washington Road Race, which is a 7.6-mile hill climb we have up here in New England. I bring my sports cardiology fellow up here whenever they want, and I tell them, if they haven't been around endurance athletes, just keep your ears open and you'll learn a lot. And this is a conversation I overheard many years back with a fellow of mine as we were waiting in line for the Aortopathy before the race, and it went like this. 4 middle-aged men getting ready to run, probably 50 years old, and the first guy says, "Man, not so sure that second plate of chili nachos and the extra couple of beers last night were such a good idea. Oh, well, they always say don't change your routine prior to races." Again, athletes may look fit and lean, but oftentimes eat terrible diets from the perspective of coronary disease. Runner 2, "Just wish my old man could see me now. He died at age 45 from a massive heart attack. Glad I got my wake-up call. Bad stuff runs in my family. This is, again, an athlete that's working very hard to run away from genetics. But remember, when he's rolled into your cath lab with a fresh coronary lesion, don't jump on the exercise until you take a good history and understand that the same thing happened to his father at a 20-year earlier age. This is a good one. Well, regardless of what happens, I've got to be better off than I was 20 years ago when I was smoking a pack a day and got short of breath just driving up this damn hill. Again, this is a reminder that when we assess causality in our patients, we need to think about their lifestyle before we met them. What we do in our 20s and 30s plays a role in where we end up in our later life. And without thinking about this, it's easy to blame other low-hanging fruit. And then finally, the best one, and this has relevance in the COVID-19 era, cough, 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 sputter. If this race wasn't only once a year, I'd be home in bed. I feel like shit. Oh, well, this little climb will help me clear out the junk. Terrible idea to push hard up 7.5 miles, 4,000 vertical feet in the midst of a viral infection, because not only when we are virally infected is our nasal and oropharynx inflamed, but so too is our vascular tree. And if there's ever a time to rupture a plaque, this is it. So we strongly encourage our athletes to stay away from high intensity exercise during viral infections. But again, these anecdotal conversations remind us to ask the question, is running really the issue in causal? And I truly believe it is not. So it's a little more complicated, and I just want to raise this in 30 seconds or more, and that is that it's not just about clinically relevant coronary disease that we have to talk about. It's about coronary calcium, and I think all of you are quite well aware of the fact that coronary calcium is alive and well in masters athletes, and it seems to be a function of how much dose exposure you've gotten. But the challenge around this is that calcification is not the same thing as clinically relevant coronary disease, at least in this population. Sedentary CAC is not necessarily athletic CAC, and it probably ends up in the athlete's coronaries for different reasons than it does in the sedentary population. And why do I say this? Well, there's a challenging thing to reconcile, and that is we know that the fitter you are, the longer you live, but we also now know that the fitter you are, the more likely you are to have CAC. So what's the prognostic significance of coronary calcium in athletes? We don't know. And perhaps more importantly, what do we do with it? Do we put every masters athlete with any coronary calcification on a statin? I'm not sure the answer to that. I have my bias, but I just want you to be aware of the controversy. So to finish up and to bring this all home, let's go back to the dose response curve and let's talk about this population of masters athletes. In my experience, and I think the literature and others who work with this group would say that the good news story is that the vast majority of recreational and competitive athletes will live in between the efficacy and the toxicity curve in this margin of safety, where they accrue all the benefits of exercise over a lifetime and never have any problems related to it. Coronary disease lives in this population, but in my synthesis of the literature, it's not because of too much exercise, it's because of the traditional risk factors they bring to the equation. A-Fib is the best example of toxicity pathology we have. And again, the challenge here is not understanding whether it's a problem, but thinking critically about how to manage it. Aortopathy, again, premature to call it that, but we know that aortic dilation appears to be pretty common in masters athletes, and we have work ahead of us to figure out whether or not it's the same thing as it would be in someone of that age with simple hypertension. And then finally, toxic exposure cardiomyopathy. Patchy fibrosis may occur in a small select group of athletes, but at this point, probably not something to be concerned about, or at least too concerned about to be screening for and changing practice around. So finally, just a reminder to all of us, even if you never work with athletes, physical activity should be part of every single encounter with every single patient. And this requires asking them about physical activity. And in doing so, we can put our patients into one of three baskets: the red, the green, or the yellow. I've talked at length about the yellow today. The green is unfortunately far too uncommon, but the red, and these are people that fail to meet physical activity guidelines, are really where we have our strongest opportunity as clinicians. And this is really an opportunity to help people both assess objective as well as perceived barriers and help them overcome these barriers to make the change they need to get themselves moving in the right direction. So with that, I'll conclude. I very much appreciate your attention. I know it was a lot of material, but it was a pleasure to be with you, and I'm happy to take any questions.
Okay, Aaron, thanks very much. That was a really fantastic talk, and I'll ask the first question before we open it up here. So since your paper on the aortopathy came out, I definitely recognized this in a few of my aortic patients, and they all want to know what they can do. I mean, I try to work through it with them, what they want to do, but do you have any any standard advice you would give a triathlete now with a 4.8 centimeter aorta without any obvious genetic etiology?
Yeah, 4.8 is an interesting choice. I mean, 4.8 clearly gets into a range that we did not see in that paper. So when we see things in excess of 4.5, 4.6, I think there's very good reason to believe that that's pathology, and those people may be different than the 4.3s, the 4.4s. In terms of the recommendations for activity in those patients, both types, one of the things I hear routinely is that people give them a specific weightlifting limit, like don't lift more than 25 pounds. And that's problematic because 25 pounds to you may be different than 25 pounds to me. And so what we typically do is we don't restrict aerobic activity at all. And we recommend that if people are interested in any form of strength training, that they confine themselves to an intensity that they can do for at least 8 to 10 continuous repetitions with comfortable breathing and avoid any form of Valsalva physiology.
Aaron, thanks for that terrific talk. I was wondering, could you just give us some broad guidelines of athletes who have COVID as far as getting back to activity? What kind of evaluations do you do, if any, on those patients?
Yeah, I wish I had a lot more time to talk about this because we're learning as we go. I think the current recommendations, and I think these are proving quite useful, is to not do anything in otherwise healthy people that had either asymptomatic or mild COVID infection, but that in folks that were really sick enough to be home in bed for long periods of time, or certainly to be hospitalized, that they should undergo some form of screening. And the recommendation right now is the triad test to include an echo, an ECG, and a high sensitivity troponin. I'm not sure how good those things are, but that's the recommendation. But I think probably the most important message is that if our patients get back into physical activity and they experience cardiopulmonary symptoms, so chest pain, shortness of breath, palpitations with exercise, that it should be an immediate recommendation to stop and come in for some testing, and to include an exercise stress test.
Thanks.
Just go ahead and sit.
Oh, hey, Aaron, thank you very much. Great talk. How and when do you expect to see age-related decrements in ability in time? It seems to me that I see a lot of aging athletes come in saying, well, I'm slower than I was last year, and I'm pretty sure there's just something wrong, not the fact that they're getting older.
Oh, it's such a great question. So first thing I'll say is age as a cause of exercise intolerance is always a diagnosis of exclusion, right? The typical aging process as it relates to cardiorespiratory fitness would suggest that at about age 45, we begin to experience a 1 mil per kg decrement in oxygen consumption, so peak VO2 per year, but that can be maintained at very high levels if people stay fit. I think the thing about aging is it's almost never a precipitous decline. So if someone comes in and they experience a true decrement over months to a year, we've got to hunt hard for some other reason. If someone, and we have many of these arguably neurotic athletes that come in with years worth of records show you that they've dropped several minutes off their marathon over the last 2 decades, well, that may be age, but rapid progression or rapid deterioration is almost never an aging phenomenon.
I have a sort of a follow-up question to that. Do you think there's anything fundamentally different about the heart of a person who's able to achieve the elite athlete status? Is there something physiologically or genetically different, or is there any evidence to that effect?
Well, there's certainly evidence to suggest that there is some genetic contribution to trainability. The degree to which genetics play into the ability to perform at elite levels has been looked at and shown to be true at the skeletal muscle level, but the degree to which that translates into myocardial structure or function, I think, is a wide open question. My guess, as are most things, is that it is both a nurture and a nature type question. There's got to be a reason why Olympic athletes tend to breed Olympic athletes, and whether that's an issue of the heart or vascular system or something else, I don't know. But I think that we'll find that there's something genetic about elite athletes that differentiates them at the level of the heart muscle.
Excellent talk. As an MRI practitioner, I wanted to ask you a question about your program in getting referrals. What has been the pattern that you have seen in terms of the outside reads? I mean, do you double check, do you bring CDs, do you repeat studies? Because I imagine that in that shared decision-making spot that you talked about as a sweet spot, you got to be pretty confident on the diagnosis before sharing, because that could be a life, changing event. How do you work things out there?
Yeah, so I moved through this quickly, but on that that how-to shared decision-making paper model that I showed you, the very first step there is confirmed diagnostic accuracy. And I tell our fellows all the time that a paper report of an imaging study is worthless, that we need to see the images and we need to review them in detail. And that includes both echo CT as well as MRI. I mean, we spend a fair bit of time reviewing MRs and finding that the reads are different in our hands, maybe different, not saying better or worse, but indeed, I think every study, when it comes down to documenting someone's livelihood, needs to be looked at carefully and in some cases repeated if the quality isn't high.
Well, there's no online questions, so is there anything else? All right, well, thank you, Dr. Baggish. We really appreciate it.
Thank you all. Take good care. Stay safe.
All right, thank you.